Welcome to the Deep Dive, the show where we cut through the noise and get straight to the insights you need to be truly well-informed. Imagine for a moment, a patient in your clinic, maybe someone you've been seeing for a while, managing their chronic kidney disease, and they have what seems like a simple fall. But that minor incident, it leads to a really devastating fragility fracture. And suddenly, this patient you've been focusing on for kidney health, they now present with this critical bone issue. And what might normally be, a relatively straightforward osteoporosis diagnosis becomes this incredibly intricate puzzle. It's complicated by altered bone metabolism, a whole cascade of interconnected challenges specific to their CKD.
Yeah, it's a scenario that's unfortunately all too common for clinicians managing these patients.
Exactly. So today we're taking a deep dive into those very specific and I think often overlooked complexities of osteoporosis when it coexists with chronic kidney disease, or CKD. This is a condition where, well, the unique physiological landscape of kidney failure creates these really distinct diagnostic and treatment hurdles for clinicians across different specialties, nephrologists, endocrinologists, but also internists and general physicians.
It really touches on multiple areas of practice.
Our mission today is to cut through that complexity. We're going to extract crucial, actionable insights from a recently published expert consensus statement specifically, an Indian consensus that's really designed to bridge existing knowledge gaps. And the aim is to provide practical, truly tailored management strategies. Think of this deep dive as, well, your shortcut to understanding the best practices and confidently navigating these often tricky treatment approaches. It's all about helping you optimize outcomes for your vulnerable CKD patients.
And the source material we're drawing from for this deep dive is really robust and highly relevant. It's the Diagnosis, Evaluation, and Management of Osteoporosis and Chronic Kidney Disease. Navigating Treatment Approaches Indian Consensus Statement, authored by Kher and colleagues, published just this year, 2025. And importantly, it's an open-access, peer-reviewed expert consensus.
That's key, the peer review aspect.
Absolutely. And it's critical because it involved a multidisciplinary panel, seasoned nephrologists and endocrinologists working together. This collaborative effort, bringing together that diverse expertise, significantly enhances the reliability and, I think, the practical applicability of its recommendations for your daily clinical practice.
Okay, let's unpack this right from the start then. We often think of osteoporosis as, primarily an age-related issue, that gradual thinning of bones we screen for in older adults. But this consensus, it unveils something quite different, almost a stealthy truth. In CKD patients, it's often this hidden crisis, completely asymptomatic until, bam, a devastating fracture occurs. What does this fundamental difference mean for how we, as clinicians, must rethink our approach? How should we be looking at every CKD patient walking into our practice? What's the true scope here?
Well, one really striking detail that emerged, and this had a powerful 92.3% consensus from the panel, is precisely that point you made. Osteoporosis in CKD patients very, very frequently remains completely asymptomatic for, well, potentially long periods. It's most commonly picked up during proactive screening rather than presenting with clear symptoms or, more alarmingly, with a fragility fracture as the very first warning sign.
So the first sign could be the fracture itself?
Exactly. And this fundamental distinction, it's really a wake-up call for clinicians. You absolutely must integrate proactive screening into your routine care for CKD patients. You can't wait for that debilitating fracture to happen. If you're a nephrologist, an endocrinologist, or an internist managing these patients, this consensus makes it crystal clear. Bone health assessment needs to be just as routine as monitoring their kidney function, their electrolytes, their blood pressure.
That's a strong statement, as routine as kidney function monitoring.
It has to be. The clinical cost of not screening early is just immense. It leads straight to delayed diagnosis, significantly increased morbidity, poorer quality of life, loss of independence. The list goes on.
So it's a condition that can silently progress, building up to this potentially life-altering event. The source highlights a pretty significant prevalence in India, specifically ranging from 17% up to nearly 32% in hemodialysis patients. Now, that's a fairly wide range, but even the lower end, 17%, is substantial. What does this data tell us about the urgency for intervention? And maybe taking a broader view, why might this prevalence be particularly high in certain regions like India? What are those underlying factors?
That's an excellent question, and it's something the panel itself critically examined. This 17 to almost 32% figure, significant as it is, was actually felt by the panel to underrepresent the true burden of the disease.
Really? Even higher?
They believe the actual prevalence is much higher, yes. And that really demands immediate and serious attention from the clinical community. Now, the reasons for this elevated prevalence in regions like India, they're multifactorial, definitely deeply rooted in public health challenges. Firstly, there's widespread vitamin D deficiency. That's a foundational component of bone health, right? And unfortunately, it's endemic in many parts of the world, India included, sometimes paradoxically despite abundant sunlight.
Right, you'd think sunlight would solve it.
But lifestyle factors, covering up maybe dietary habits that don't provide sufficient calcium or vitamin D, and sometimes even genetic predispositions affecting vitamin D metabolism, play a huge role. Secondly, specific dietary habits, maybe diets low in calcium or perhaps high in phosphorus, can contribute significantly to these bone mineral imbalances we see in CKD. And critically, challenges related to healthcare access, socioeconomic factors, and sometimes just a lack of public awareness often delay diagnosis and intervention. This allows the disease to progress unchecked for far too long.
That makes sense. A convergence of factors.
Exactly. And these regional nuances, they highlight precisely why a region-specific guideline like this Indian consensus is incredibly valuable. It addresses the unique patient profiles and resource constraints found locally while still offering principles that are broadly applicable globally.
Okay, so beyond just the numbers, the prevalence, the source really digs deep into the incredibly complex pathophysiology here. It's clearly not just about getting older, is it? It's multifactorial, deeply intertwined with CKD-MBD, that's mineral and bone disorder, secondary hyperparathyroidism, altered bone remodeling dynamics, various metabolic disturbances, even chronic inflammation. For our audience of clinicians, can you really break down what makes bone health in CKD so uniquely challenging to manage? How does it differ sharply from the primary osteoporosis many of us might be more familiar with?
Yeah, let's connect this to the bigger picture for your clinical practice.
Huh.
CKD-MBD, chronic kidney disease, mineral and bone disorder, is absolutely the central player here. It's not just isolated issues. Think of it as a complex, interconnected cascade. So as kidney function declines, the kidneys lose their ability to properly activate vitamin D. That's step one. This leads directly to low serum calcium levels.
Okay.
In response to this persistent low calcium, the parathyroid glands, they basically go into overdrive. They start producing excessive amounts of parathyroid hormone, PTH, and that's your secondary hyperparathyroidism. Now, while PTH tries its best to correct the calcium imbalance by pulling calcium from bone and increasing kidney reabsorption, in doing so, it inadvertently causes these widespread abnormalities across several key aspects of bone health. It affects bone turnover, how quickly old bone is replaced by new. It affects mineralization, the proper deposition of calcium and phosphate into the bone matrix. It affects overall bone volume and, crucially, its structural strength.
So PTH is trying to help, but actually causing broader problems in the bone itself.
Precisely. And on top of these profound metabolic imbalances, you have the direct effects of uremia, that accumulation of toxins and waste products in the blood due to kidney failure. These uremic toxins further negatively impact both bone and muscle function. They can directly inhibit osteoblasts, those are the bone-building cells, and promote osteoclast activity, the bone-resorbing cells. This leads to a completely dysregulated bone remodeling process.
A double whammy then, metabolic and toxic effects.
Exactly. Plus, uremia contributes to chronic inflammation, which itself can impair bone formation. So this entire systemic problem, rather than just a localized bone thinning like in primary osteoporosis, is what makes bone health in CKD so profoundly challenging. It necessitates a holistic, integrated approach to diagnosis and management that goes far beyond just looking at bone density.
That really does sound like a diagnostic minefield for clinicians. And the source points out something related, that traditional tools like DXA scans, the gold standard for measuring bone mineral density, BMD, in the general population, they may not fully capture the true picture of bone quality in CKD patients, often due to confounding factors like vascular calcification, which can artificially inflate those BMD readings, and also just a fundamentally altered bone composition in CKD itself. What are the practical clinical implications of this diagnostic challenge when you're trying to accurately assess a patient's real fracture risk?
This necessitates a really critical reevaluation of BMD results when you're interpreting them for your CKD patients. While DXA absolutely remains a crucial tool, and it's still the investigation of choice for screening for osteoporosis, its known limitations in the specific population mean that you, as a clinician, simply cannot rely solely on the T-score.
So a normal T-score might be misleading.
It definitely can be. A common pitfall is misinterpreting an apparently normal BMD in a CKD patient because of underlying vascular calcification, which can make the bones appear denser on the scan than they actually are structurally sound. This false sense of security can easily lead to underdiagnosis and critically delayed treatment. To get a clearer, more accurate picture, clinicians need to consider a broader array of insights. This includes looking at dynamic parameters like bone turnover biomarkers. We'll talk more about those which give you a sense of the bone's metabolic activity.
Right, like BSAT and ITTAs.
Exactly. And where available, potentially utilizing more advanced imaging techniques like high-resolution peripheral quantitative computed tomography or HRPQ-CT. HRPQ-CT provide a 3D assessment of bone microstructure and strength, offering a much clearer, more nuanced understanding of the underlying bone pathology, going way beyond just density.
That sounds much more informative, but probably less accessible.
It is generally less accessible, unfortunately. But it helps differentiate between various forms of CKD-MBD, like high turnover bone disease versus low turnover or adynamic bone disease. It really reinforces the point that in CKD, a DXA reading is a starting point for screening, yes, but it's not the sole or definitive determinant of bone strength and fracture risk. It must be interpreted within the broader clinical context of that specific patient's CKD.
Okay, that's a really important caveat on DXA. Now, this deep dive is built on a very strong foundation, that expert consensus you mentioned. One of the things that struck me was the deliberate effort to bring together such a diverse, multidisciplinary panel. Can you elaborate a bit more on exactly who was involved in crafting this consensus, and why was that multidisciplinary perspective so absolutely critical for producing recommendations that are both robust and clinically relevant for us, the practitioners?
The panel was meticulously assembled, and its composition really tells a story about the intention behind it. It comprised 13 leading Indian experts and one highly respected international expert, Dr. Thomas Nicholas from Columbia University. But what's truly insightful is the balance. It included a significant representation of nephrologists, 10 of them, working alongside 3 endocrinologists.
10 nephrologists and 3 endocrinologists, okay.
Yes, and this multidisciplinary approach was absolutely essential because it ensured a comprehensive, truly holistic perspective. Nephrologists bring that deep understanding of kidney disease progression, fluid and electrolyte management, the complexities of dialysis, and how uremia affects the body systemically. Endocrinologists, on the other hand, bring their core expertise in bone metabolism, hormonal regulation, calcium phosphate homeostasis, and the nuances of specific osteoporosis treatments.
So they cover both sides of the coin, kidney and bone.
Precisely. This blend helps bridge the typical silos that can sometimes exist in complex patient care. It directly addresses that intricate crosstalk between kidney disease and bone metabolism, which, as we've discussed, is so central to CKD-associated osteoporosis. And their selection wasn't arbitrary. It was based on their vast clinical experience, their significant academic contributions in the field, and their active involvement in relevant professional societies. This lends immense credibility and practical weight to the recommendations.
So real-world experience factored in heavily.
Absolutely. It meant they brought not just academic knowledge, but practical, real-world clinical insights gained from managing these challenging patients day in and day out.
It sounds like this wasn't just a casual meeting of minds then. The methodology described in the source seems quite rigorous. They conducted comprehensive literature reviews using multiple extensive databases, PubMed, Medline, Embase, Cochrane, Web of Science, Google Scholar, covering a wide time frame, 2000 to 2023. And they even used the grade framework for evidence grading. For clinicians looking at these recommendations for their daily practice, why is this level of methodological detail and transparency so incredibly important? What does it signal about the reliability of this guidance?
That's a critical point for any clinician evaluating new guidelines, isn't it? This level of methodological rigor directly addresses the fundamental question: how reliable and trustworthy are these recommendations? Can you truly implement them with confidence in your daily practice? The use of the grade framework, for instance, isn't just some academic exercise. It systematically assesses the quality of the evidence based on various crucial factors. The strength of the study design, where they randomize controlled trials or observational studies, sample size, the methodology used, consistency of results across different studies, and crucially, the clinical relevance of the findings.
So it filters the evidence effectively.
Yes, very effectively. They didn't just review every article they found. They initially identified 132 potential articles, which were then meticulously narrowed down, screened, and assessed, resulting in 24 high-quality studies that directly addressed the 11 key clinical questions the panel had formulated beforehand. This rigorous, transparent process of evidence evaluation builds immense confidence. It means the guidance provided is firmly grounded in reliable and relevant data, allowing clinicians like you to trust that these are not just opinions, but genuinely evidence-backed recommendations designed to inform and elevate best practices.
It's like knowing the foundation is solid.
Exactly. It's like knowing your car has passed all its safety checks before you take it on a long journey. You feel more secure.
So what does this all mean for the clinician on the ground, faced with real patients and complex decisions every day? The panel gathered opinions on those 11 key clinical questions, covering everything from prevalence and diagnosis right through to specific treatment pathways and algorithms. And they reached a remarkably high level of agreement, you mentioned, ranging from 80% all the way up to 100% on some critical points. How was this achieved, especially since the source mentions they diverged from the typical multi-round Delphi method, opting for a single round via a virtual advisory board? And what does such strong agreement signify for the practicality and maybe the implementability of these guidelines in a busy clinical setting?
Well, the fact that such strong agreement was achieved so efficiently in that single round via a virtual advisory board rather than a drawn-out multi-round Delphi process is actually quite telling. It signifies, I think, a profound shared understanding and a clear unified trend toward adopting precise, actionable approaches in clinical practice among this expert group. It suggests the core concepts weren't highly contentious among them.
So they were largely on the same page from the start.
It seems that way for many key areas. It implies that these recommendations are not merely theoretical concepts or some watered-down compromise between dissenting views. Instead, they represent a practical, actionable framework for managing osteoporosis in CKD. The high consensus indicates that these are widely accepted best practices among these leading experts. And they directly address existing knowledge gaps that we know exist among nephrologists and other clinicians managing CKD.
Okay.
So for you, the clinician, it means you have a consolidated, expert-backed roadmap. It simplifies complex decision-making right there at the point of care. It provides clear pathways, reducing ambiguity and allowing for more consistent and effective patient management, which is absolutely invaluable in a busy clinical environment.
All right. Consistency is key.
It streamlines the thought process, ensuring critical considerations aren't missed when you're juggling multiple patient issues.
Okay, this makes sense. Let's pivot to segment 3 then. Pinpointing the problem diagnosis and risk assessment. Here's where it gets really practical for clinical practice, I think. The panel reached that resounding 92.3% consensus on a crucial point. The most common presentation of CKD-induced osteoporosis is asymptomatic, detected during screening. For our audience of clinicians, what's the fundamental takeaway here? What's the real clinical cost of not screening early? And maybe what are some practical barriers clinicians might face in actually integrating this into their busy routines?
This is arguably one of the most critical takeaways for your daily practice. The message is loud and clear. You absolutely must actively and periodically screen your CKD patients for early detection of osteoporosis. Don't wait for symptoms. The consensus unequivocally emphasizes that early screening using dual energy X-ray absorptiometry, DXA, is essential. Now, while general population guidelines typically suggest screening women 65 and older, men 70 and older.
Right, the standard guidelines.
Yeah. For CKD patients, earlier screening is strongly advised. This is particularly true for postmenopausal women and any individual aged 50 years or older with CKD. They are at a demonstrably higher risk of fractures because of the underlying kidney disease and all those associated metabolic disturbances we talked about.
So 50 and older for CKD patients is the key threshold.
That's the guidance here, yes. And the clinical cost of not screening early, it's immense. It leads directly to delayed diagnosis, often resulting in patients presenting only after they've suffered a debilitating fragility fracture. And these fractures, they significantly increase morbidity, mortality, they reduce independence, they dramatically impact the patient's quality of life. It's a cascade of negative outcomes.
And the barriers.
Yeah.
What stops clinicians from doing this routinely?
Well, common practical barriers might include perhaps limited awareness among some clinicians about just how high the prevalence of osteoporosis is in CKD. Sometimes it's resource constraints, access to DXA machines, cost, reimbursement issues, and frankly, sometimes it's the sheer volume of other critical CKD-related complications that need managing anemia, hypertension, fluid balance.
Right, the competing demands on time and resources.
Exactly. But this consensus really urges you to prioritize bone health screening. It needs to be seen as a non-negotiable part of comprehensive CKD care, not an optional add-on.
Okay, point taken. Now, traditional DXA gives us bone mineral density, BMD. But the source makes a very strong case for also evaluating bone turnover status. It explicitly states, with 84.6% agreement, that bone-specific alkaline phosphatase, or BSAP, is a better marker than intact parathyroid hormone, IPTH, for distinguishing between high versus low bone turnover disease. For making treatment decisions, why is this distinction so incredibly critical for clinicians? And what's the physiological reason behind BSAP's apparent superiority here?
This specific emphasis on BSAP is a really vital clinical nuance. The fundamental physiological reason behind BSAP's superiority as a bone turnover marker, specifically in CKD patients, is that BSAP is not cleared by the kidneys.
Ah, okay, that's the key difference.
Yes. Unlike IPTH, which accumulates as kidney function declines because it's cleared by the kidneys, this means IPTH levels can become complex and, frankly, quite confounding in CKD, especially with secondary hyperparathyroidism driving levels up for reasons other than just bone turnover. So IPTH becomes less reliable on its own to accurately reflect true bone turnover. BSAP, being kidney independent in its clearance, provides a clearer, more direct snapshot of osteoblast activity and bone formation rate.
Makes sense.
Now, critically, the panel further suggested that combining both BSAP and IPTH could be even more beneficial in accurately differentiating high versus low bone turnover. This then guides a truly tailored treatment approach.
Okay, so using both gives the best picture. But why is knowing high versus low turnover so critical for treatment?
Because a patient with high bone turnover, meaning their bone is breaking down and reforming very rapidly, often driven by high PTH, needs a fundamentally different treatment approach than a patient with low bone turnover, or adynamic bone disease, where there's very little bone activity leading to brittle, non-repairing bone. For example, anabolic agents, which actively build bone, are generally preferred for low turnover disease, whereas anti-resorptive agents, which slow down bone breakdown, are typically used for high turnover disease.
Got it. Using the wrong one could be harmful.
Potentially, yes. Without knowing the underlying turnover status, you could inadvertently choose a therapy that worsens the patient's bone health. For instance, giving a potent anti-resorptive to someone who already has low turnover could push them further into adynamic bone disease. And while bone turnover markers fall into two main categories, formation markers like osteocalcin, BSAP, P1NP, and resorption markers like CTX, NTX, TRAP for your daily practice, focusing on BSAP and IPTH is the key. Actionable markers for assessing bone turnover will likely yield the most immediate insights for guiding therapy effectively. The goal is to understand, is the bone overactive or underactive?
Okay, very clear. Now, when it comes to assessing overall fracture risk, the Fracture Risk Assessment Tool, or FRAX, comes up. The panel agrees, with a robust 92.3% consensus, that FRAX is a valuable tool for assessing fracture risk in CKD patients aged 40 and older, even without BMD input. Furthermore, they recommend it should be utilized before initiating treatment. What's the practical utility of FRAX in a CKD setting, especially given its known limitations, like not directly incorporating EGFR or CKD status into its calculation? How do we reconcile its utility with these acknowledged shortcomings?
Yeah, that's a genuine clinician's dilemma, isn't it? FRAX is a tool many of us lean on for estimating fracture risk, but its limitations in CKD, especially not directly including EGFR or the presence of CKD as a risk factor, are a known challenge. However, despite this specific limitation, its utility in CKD patients across all stages has been clearly demonstrated in various studies. The panel's strong endorsement here really highlights its value, particularly in regions or clinical settings where DXA scans might be unavailable, unaffordable, or just logistically difficult to obtain readily.
So it's a good starting point, especially if DXA isn't available.
Exactly. FRAX can still provide a useful baseline assessment of that patient's 10-year probability of major osteoporotic fracture and hip fracture. It helps clinicians prioritize patients who might need more aggressive investigation or interventions. It offers a standardized way to assess multiple clinical risk factors simultaneously. But it's crucial for clinicians to note that peripheral calcaneal quantitative ultrasound, or QUS, is not recommended as a standalone diagnostic tool for osteoporosis and CKD.
Okay, QUS for screening, not diagnosis.
Precisely. While it can be useful as a preliminary screening method, maybe in a primary care setting, to identify patients who might warrant a referral for more definitive DXA, it should absolutely not replace DXA or other definitive diagnostic evaluations in the CKD population. The distinction is key. QUS screens, DXA diagnoses, and FRAX estimates risk using multiple clinical factors, sometimes including DXA results.
Right. So to synthesize the diagnostic front for our clinicians, it's clearly not just about a simple T-score from a DXA. The consensus states that a patient with a T-score of 2.5 or lower definitely needs treatment consideration. But importantly, so does someone with maybe normal or osteopenic BMD, but who has a clear history of a fragility fracture. And crucially, a multidisciplinary approach involving cross-referrals is absolutely essential. Can you connect these dots for our audience, emphasizing the practical implications for their diagnostic workflow? How should this change how they approach diagnosis?
Indeed, the panel reached 100% agreement on both of those critical points, which really speaks volumes about their foundational importance for you, the clinician, in your daily work. The emphasis on fragility fracture history, even in the presence of a seemingly normal BMD, highlights the paramount importance of a comprehensive patient evaluation that extends far beyond just looking at density metrics.
The history is key.
Absolutely. This is a common clinical scenario. A patient might have a DXA-T score of, say, -1.8, technically osteopenia, but they present with a vertebral compression fracture from simply bending over. That fracture tells you far more about their underlying bone fragility than the density number alone. It means a clinician should always take a detailed patient history, actively inquire about any path fractures, especially low trauma ones, and consider the entire clinical context holistically. Furthermore, the 100% consensus on needing a multidisciplinary approach means that cross-referral is vital. For example, nephrologists, who are often the primary managers of CKD patients, should be proactively screening these patients if they have risk factors for osteoporosis.
And referring when needed.
Yes, and be ready to collaborate closely with endocrinologists or perhaps rheumatologists or bone metabolism specialists when the bone pathology becomes more complex or when specialized treatments like anabolic agents are being considered. This collaborative pathway ensures that patients receive the most comprehensive and expert care possible, breaking down those traditional silos in patient management for optimal bone health outcomes. It's about building a complete, holistic picture of the patient's individual risk profile.
That makes perfect sense. Let's move into segment 4 then. Navigating treatment strategies in CKD-OP. Before we even dive into specific osteoporosis drugs, the consensus with a strong 92.3% agreement makes a crucial, almost foundational point. Renal osteodystrophy, or ROD management, is necessary prior to managing CKD-induced osteoporosis itself. Why is this sequence so critically important for clinicians? What are the practical implications in terms of patient care pathways? How do you actually implement this?
This truly is a cornerstone for effective treatment, and it's a critical, practical first step for clinicians. You simply cannot effectively treat CKD-induced osteoporosis without first attempting to stabilize the underlying bone metabolism issues caused by the kidney disease itself, the ROD. Think of it like trying to build a house on shaky, unstable ground. It just won't stand strong, no matter how good the materials are. Managing ROD first helps to correct, or at least improve, those profound disturbances in calcium, phosphorus, vitamin D, and PTH that are so central to CKD and BD.
So stabilize the environment first.
Exactly. This stabilization makes any subsequent osteoporosis-specific treatments far more effective and, importantly, more appropriately tailored to that individual patient's specific needs and underlying bone turnover status. Practically, this means focusing first on interventions like dietary phosphate restriction, the judicious use of appropriate phosphate binders, ensuring adequate vitamin D repletion, which often requires using activated vitamin D analogs like calcitriol or paracolcitol if traditional supplementation isn't effective due to the impaired kidney activation.
Right, the kidneys can't activate regular vitamin D.
Correct. And it also involves managing PTH levels, perhaps with calcimimetics like senecalcit if secondary hyperparathyroidism is severe and contributing to high bone turnover. The panel recommends that clinicians use those biochemical parameters, calcium, phosphate, vitamin D levels, and PTH, to rigorously monitor the effectiveness of their ROD management strategy. Furthermore, those bone biomarkers we discussed, BSAP and IPTH, can be utilized not just for diagnosis, but also to assess patient compliance with the ROD regimen and to gauge its overall treatment effectiveness before you even consider starting specific anti-osteoporosis medications like bisphosphonates or denosumab.
So ROD management is step 1, monitored by labs and maybe biomarkers. Then you think about OP drugs.
That's the sequence recommended, yes.
Okay. Now, when tailoring treatment for the osteoporosis component, identifying specific risk factors is absolutely key. The panel identified a pretty comprehensive list: advanced age, female sex, low BMI, malnutrition, hypogonadism, glucocorticoid excess, like from long-term steroid use, smoking, excess alcohol consumption, high sclerostin levels, dialysis vintage, meaning how long a patient has been on dialysis, hyperphosphatemia, hyperparathyroidism, and even hyperprolactinemia. For our audience, what's the clinical significance of recognizing these specific factors? How should they use this list to guide therapy and maybe stratify patients?
Recognizing these factors allows clinicians to proactively identify those high-risk patients who need earlier intervention and much closer monitoring. It's not just a laundry list to tick off. Each factor provides a crucial piece of the puzzle for developing an individualized therapy plan. For instance, the panel specifically emphasized malnutrition and hypogonadism as critical issues that demand immediate attention and management, particularly within the dialysis population, where they are unfortunately highly prevalent.
Why those two specifically?
Well, malnutrition directly impacts the building blocks needed for bone matrix formation and affects overall muscle strength, increasing fall risk. Hypogonadism, low testosterone in men, low estrogen in women, removes a critical bone protective hormonal influence, accelerating bone loss. Addressing these potentially reversible factors through nutritional support or perhaps hormone replacement therapy where appropriate and safe can significantly improve bone health independent of or complementary to specific osteoporosis medications. Similarly, actively managing hyperphosphatemia and hyperparathyroidism are direct components of that initial ROD management step, which prevent further bone damage.
So some risk factors are targets for intervention themselves.
Exactly. These factors don't just exist in isolation. They directly guide your initial assessment and subsequent treatment decisions. They shape the individualized approach you'll take with each patient. It's essentially a comprehensive checklist to ensure you're not missing any compounding factors that could undermine your treatment efforts, or perhaps point towards a need for a more aggressive or specific therapeutic strategy.
Right. It helps tailor the approach. Now, this is where the rubber meets the road for many clinicians, the actual drug choices. The source provides a clear EGFR-guided algorithm, which achieved that remarkable 100% consensus for specific therapies based on bone turnover status. Let's start with the foundational step they mention, lifestyle modifications, and then really delve into the specifics of managing high versus low bone turnover disease according to this algorithm.
Absolutely. Lifestyle modifications, including appropriate aerobic and especially weight-bearing exercises, are always the starting point. They are the non-pharmacological foundation for bone health and should be encouraged for all patients, provided they are medically stable and physically able to participate safely. Now, for the pharmacologic approaches, the algorithm is indeed quite clear and provides a crucial roadmap for you. If a patient presents with high bone turnover disease, meaning their bones are actively breaking down and reforming at an accelerated, often inefficient pace, usually driven by high PTH.
Okay, the overactive bone.
Yes. And if their EGFR is greater than 40 mmol/min 1.73 mg/2, then the recommendation is to consider either bisphosphonates or denosumab. This is because these agents primarily work by inhibiting bone resorption, slowing down that excessive breakdown. However, that same patient with high bone turnover has an EGFR that is less than 40 mmol/min 1.73 meters apart, then denosumab alone is suggested.
So bisphosphonates drop off below EGFR 40 in this algorithm for high turnover.
Correct. This is a critical distinction driven by those concerns we discussed about bisphosphonate accumulation and potential renal toxicity or oversuppression of bone turnover in lower EGFR settings. Now, conversely, for patients diagnosed with low bone turnover disease where bone activity is sluggish, bone formation is impaired, leading to anadynamic or osteomolastic features.
The underactive bone.
Exactly. In that scenario, the preference shifts entirely towards anabolic agents, which are the bone-building medications designed to stimulate osteoblast activity. This EGFR-guided, turnover-specific approach is absolutely critical for both patient safety and treatment efficacy. It ensures the right drug class is used for the right underlying bone pathology at the right stage of CKD.
Okay, that's a very clear distinction. Let's unpack the specifics of those pharmacologic agents then, because they each have different considerations, especially in CKD. Starting with the bisphosphonates, these inhibit osteoclast-mediated bone resorption, slowing bone breakdown. Common ones include zoledronate, usually 5 milligrams IV yearly, alendronate, 70 milligram orally weekly, pimidronate, maybe 60 milligram IV every 3 months, rezendronate, 5 milligram orally daily, and ibandronate, 150 milligrams orally monthly or 3 milligram IV every 3 months. What are the key cautions here, particularly concerning patients with advanced CKD or those on hemodialysis? What are the practical implications for using them, given that EGFR 40 cutoff?
Bisphosphonates require extremely cautious use in patients with advanced CKD, say EGFR below 30 or 40, depending on the specific agent and guidelines, or those on hemodialysis. The primary concerns are twofold: the risk of inducing or worsening autonomic bone disease and the potential for renal toxicity. Autonomic bone disease, remember, is that severe complication where bone turnover becomes too low. The bone becomes brittle, unable to repair microdamage, and ironically, this can increase fracture risk despite potentially higher density readings. This happens because bisphosphonates are renally cleared and can accumulate in patients with impaired kidney function, leading to an oversuppression of normal bone turnover.
So too much of a good thing becomes bad?
In a way, yes. And while randomized controlled trials haven't consistently shown a significant EGFR decline with oral bisphosphonates in milder CKD, intravenous bisphosphonates, particularly zoledronate, are definitely associated with an increased risk of acute kidney injury, AKI. Therefore, they require particular caution and often dose adjustment or avoidance in lower EGFR ranges. Clinicians must meticulously assess renal function before initiating and monitor it during IV bisphosphonate administration. Beyond the kidney-specific issues, you must also remain vigilant for common side effects like hypocalcemia, especially after IV doses, those rare but severe atypical femoral fractures, gastric irritation, and esophagitis with oral forms.
Right, the GI issues with oral ones.
Exactly. And the rare but serious complication of osteonecrosis of the jaw, ONJ, especially in patients undergoing dental procedures or with poor oral hygiene. So careful patient selection based on turnover status in EGFR, meticulous dosing, ensuring adequate calcium vitamin D intake, and rigorous monitoring are absolutely paramount to safely using these agents in the subset of CKD patients where they might still be considered appropriate, generally those with higher EGFR and confirmed high turnover. It's a definite risk-benefit assessment every single time.
Okay, very clear cautions for bisphosphonates. Now, denosumab, the ARNKL inhibitor, seems to be positioned as a cornerstone, especially for patients with lower EGFR, largely due to its non-renal clearance. The standard dosage is 60 milligrams subcutaneously every 6 months. What are the practical considerations for its use, particularly regarding that risk of hypocalcemia, which the consensus seems to highlight quite strongly? How frequently should clinicians actually monitor calcium levels, and what are other key side effects to watch for?
Denosumab has indeed been shown to significantly increase bone and mineral density and reduce fracture risk across various populations, including CKD patients. And importantly, it achieves this without the direct nephrotoxic concerns associated with some other options, making it a particularly valuable choice for CKD patients, especially those with lower EGFR, where bisphosphonates might be contraindicated or used with extreme caution. However, the risk of hypocalcemia is a very real and potentially serious concern, particularly in patients with advanced CKD, stages 4 or 5 or on dialysis, where calcium and vitamin D metabolism are already severely disrupted.
Because their kidneys aren't managing calcium well anyway?
Precisely. The kidneys play that crucial role in activating vitamin D and reabsorbing calcium. When they fail, patients are inherently vulnerable to low calcium levels. Denosumab works by inhibiting osteoclasts, which reduces calcium release from bone, potentially tipping these patients into symptomatic hypocalcemia if they aren't properly managed. The consensus recommends regular monitoring of serum calcium and PTH levels is absolutely essential. Specifically, they suggest calcium levels should be measured more frequently in the first 2-3 weeks post-injection due to this heightened risk. Perhaps even every few days initially in high-risk patients, then maybe weekly for a few weeks before potentially returning to a less frequent schedule once stable.
That's quite intensive monitoring initially.
It needs to be in vulnerable patients. It's also crucial that patients receive adequate prior vitamin D and calcium supplements before initiating denosumab, and this supplementation must be maintained consistently throughout treatment. You need to ensure the calcium tank is full before you turn off the tap from the bone. Clinicians should also be keenly aware of the potential for rebound bone loss upon discontinuation of denosumab. If treatment is stopped abruptly without transitioning to another anti-resorptive agent, like a bisphosphonate if appropriate, there can be a rapid increase in bone turnover and a loss of the accrued BMD gains, sometimes leading to multiple vertebral fractures.
So stopping it isn't straightforward either.
No, it requires a clear plan. Elevated PTH levels can also be a noted side effect, and patient education on recognizing the symptoms of hypocalcemia like tingling, muscle cramps, spasms, is absolutely vital so they can seek help promptly.
Good points. What about other agents, like calcitonin, typically 50 to 100 units daily IMSC, or the nasal spray 200 units daily? And then the newer agents like romosozumab, 210 milligrams subcutaneously monthly, the sclerostin inhibitor, or raloxifene, 60 milligram orally daily, a selective estrogen receptor modulator. How do these fit into the treatment armamentarium for CKD patients? What are their specific pros and cons in this population?
Okay, let's take those one by one. Calcitonin, while it is an anti-resorptive agent and can offer some analgesic effect, particularly in acute vertebral fractures. Its overall efficacy for long-term fracture prevention is generally considered less robust compared to bisphosphonates or denosumab. Plus, it carries risks of hypersensitivity reactions, can cause hypocalcemia, and there's a potential, though debated, risk of malignancy associated with long-term nasal spray use. The nasal spray also has local side effects like nosebleeds and irritation, so its role is fairly limited now. Romosozumab is particularly interesting for clinicians because it offers that unique dual action. It increases bone formation by inhibiting sclerostin, which is a protein that naturally puts the brakes on bone formation, while simultaneously decreasing bone resorption.
So it builds bone and stops breakdown.
Exactly. A powerful combination, especially for patients at very high fracture risk. However, clinicians need to be very mindful of its noted side effects. There's a black box warning regarding potential increased risk of major adverse cardiovascular events, things like heart attack and stroke. So it requires careful patient selection, avoiding use in those with recent cardiovascular events. Other side effects include hypocalcemia, atypical femoral fractures, and that risk of jaw osteonecrosis, similar to other potent agents.
So potent, but needs careful cardiovascular assessment.
Absolutely. Raloxifene, on the other hand, is a selective estrogen receptor modulator, or SERM. It's primarily used in postmenopausal women, particularly those who might also have an increased risk of breast cancer, as it has protective effects there. It acts like estrogen on bone, reducing resorption, but can block estrogen effects elsewhere. Its main risks are venous thromboembolism, blood clots, and causing or worsening hot flashes. Generally, it has a good renal safety profile, but its efficacy might be less pronounced than other agents, especially for non-vertebral fractures. So the choice among these agents, as with all pharmacological therapies, depends heavily on that individual patient's specific fracture risk profile, their comorbidities, especially cardiovascular for romosozumab, VTE risk for raloxifene, the agent's unique side effect profile, local availability and formulary coverage, and cost. Each option requires a very careful, individualized benefit-risk assessment tailored precisely to that patient sitting in front of you.
Okay, that's a helpful overview. And then for the other side of the coin, low bone turnover, the focus shifts entirely to anabolic therapies. These are the PTH analogs like teriparatide, usually 20 micrograms subcutaneously daily for a maximum of 2 years, and abaloparatide, 80 micrograms daily. What are the specific considerations and precautions for using these bone-building agents in CKD patients, especially given that CKD patients often have issues with PTH already, like secondary hyperparathyroidism?
Right, PTH analogs primarily work by stimulating osteoblast activity and promoting bone formation, which is exactly what's needed for patients diagnosed with low bone turnover disease or adynamic bone. They essentially aim to wake up the sluggish bone. However, teriparatide specifically should be administered very carefully in patients with severe renal impairment, say an EGFR less than 30 LM/mL in 1.73 meters medaling R. This is because its elimination can be delayed in such patients, potentially leading to higher systemic exposure and an increased risk of side effects like hypercalcemia. Furthermore, its efficacy might be reduced in the presence of already significantly elevated baseline PTH levels, which, as you pointed out, is common in CKD patients due to secondary hyperparathyroidism. If PTH is already very high and perhaps driving some abnormal bone changes, adding a PTH analog might be less effective or potentially counterproductive. You ideally want to use it when baseline PTH isn't excessively high.
So checking PTH first is important.
Absolutely. And as with all medications, there are potential side effects to monitor for. Hypercalcemia is a key one, requiring careful monitoring of serum calcium levels, especially during the first few weeks and months of therapy. Other side effects can include nausea, leg cramps, dizziness. There's also a theoretical concern about potential reduction in cortical bone density with prolonged use, although trabecular bone improves. And finally, there's that rare but serious risk of osteosarcoma, which has been observed in animal studies at high doses, leading to the 2-year lifetime limit on treatment duration. Given all these considerations, careful patient selection, confirming low turnover, checking baseline calcium and PTH, meticulous monitoring of calcium levels throughout the entire treatment course, and adhering to treatment duration limit are absolutely paramount when using these agents in the CKD population.
Okay, 2-year limit, watch calcium, check PTH first. Got it. Now, once treatment is initiated, monitoring efficacy is, of course, absolutely crucial. The panel highly recommends, with a 92.3% agreement, following up osteoporotic patients through evaluation of BMD changes using DXA scans either yearly or perhaps every 2 years. What's the fundamental importance of this consistent monitoring for clinicians managing these complex patients? And maybe beyond just a number on a DXA scan, what really defines treatment success in this context?
Regular DXA assessments are absolutely vital for tracking those bone density changes over time. They provide a reliable, objective measure of the treatment's biological effect on bone mass. This consistent monitoring empowers clinicians to adjust therapy as needed. Maybe the dose needs tweaking, maybe the drug isn't working, maybe compliance is an issue. It ensures that the chosen pharmacological approach is indeed optimizing bone health and effectively mitigating fracture risk in this particularly vulnerable patient population. However, and this is a crucial point, treatment success in CKD-OP isn't just about the T-score improving on a DXA scan. That's important, but it's only part of the picture.
What else should we look at?
We also need to look at clinical outcomes. Has the patient experienced any new fragility fractures since starting treatment? That's a major indicator of success or failure. Are there bone turnover markers, if you're monitoring them, moving in the desired direction? For example, are they normalizing in high turnover disease, or perhaps increasing slightly with anabolic therapy in low turnover disease? Are their biochemical parameters, calcium, phosphate, PTH, remaining stable and within acceptable target ranges for their stage of CKD? This consistent feedback loop from monitoring, combining clinical outcomes, DXA results, and relevant lab parameters allows clinicians to evaluate if the chosen therapy is truly working as intended.
It's a multifaceted assessment then.
Exactly. It helps decide if dosages need adjustment, if adherence needs reinforcement, or if a switch to a different agent or class of agent is necessary. This approach aligns perfectly with broader international perspectives that emphasize the necessity of comprehensive, ongoing monitoring to ensure treatment goals are met and, just as importantly, to prevent adverse outcomes. Without this consistent feedback, clinicians would, quite frankly, be flying blind, unable to truly assess the real-world impact of their interventions on the patient's bone health and fracture risk.
That makes sense. Okay, let's move into our final segment, segment 5. Towards standardized care, practical algorithms, and future outlook. What's really fascinating here is the panel's deep commitment to providing a truly practical framework for clinicians. They agreed, with 100% consensus, on the feasibility and utility of a comprehensive algorithm for the diagnosis and management of osteoporosis and CKD. Can you walk us through the essential components of this algorithmic flow? Give our listeners a clear, step-by-step roadmap for their clinical practice based on this consensus.
Yes. This algorithm really aims to integrate all those key steps we've discussed into a logical sequence, providing that clear roadmap for clinicians to standardize care and, importantly, avoid missing critical steps along the way. It begins, as it should, with an initial comprehensive risk assessment. That means considering all those factors we listed earlier: age, sex, BMI, fracture history, comorbidities, medications like glucocorticoids, lifestyle factors, dialysis vintage, etc. This is followed by a thorough bone turnover evaluation. And remember, the consensus suggests using a combination of BSAP and IPTH here to more accurately classify the underlying bone pathology as either high or low turnover disease.
Right, turnover status is central.
Absolutely. Then, crucially, and this is a central tenet of the consensus reinforced in the algorithm, it mandates that prior renal osteodystrophy, ROD management, you must address and stabilize the metabolic environment first before moving to osteoporosis-specific therapies. The algorithm then guides clinicians towards regular bone mineral density monitoring, typically via DXA, to track progress in response to therapy over time, usually annually or biennially. And then, based on both the confirmed bone turnover status, high versus low, and the patient's current EGFR level, it directs the tailored use of either anti-resorptive therapies, like denosumab, or bisphosphonates if EGFR is adequate and turnover is high, or anabolic therapies, like teriparatide if turnover is low.
So it puts all the pieces together in order.
Yeah, exactly. It's essentially a clinical flowchart designed to simplify complex decision-making. It ensures that every critical aspect, from the initial assessment and risk stratification through turnover evaluation and ROD management, right up to specific drug selection and ongoing monitoring, is addressed systematically. The ultimate goal is to lead to more consistent, safer, and ultimately more effective patient care for your CKD population suffering from osteoporosis.
That sounds incredibly useful. Now, no deep dive, especially one based on a consensus statement, would be complete without acknowledging the nuances and limitations. The statement itself openly discusses its limitations. These include its reliance on expert opinion, which always carries some potential for bias, no matter how rigorous the process. Also, the single-round consensus process, which, as you noted, diverged from the multi-round Delphi method and might perhaps limit the depth of exploration of diverse opinions. And finally, its primary tailoring to the Indian healthcare context.
How should our listeners who might be practicing in very different regions with different healthcare systems, resource availability, and patient demographics interpret these limitations when they're considering applying these guidelines? What sort of adaptations might be necessary?
That raises a really important question regarding generalizability, and it's something every discerning clinician should absolutely consider when reviewing any guideline, especially one developed in a specific regional context. While the core principles laid out are scientifically robust, clinicians should indeed acknowledge that variations in healthcare infrastructure, things like the availability of specific diagnostic tools like HRP-QCT or easy access to certain advanced medications, can differ significantly. Resource availability, including funding for regular DXA scans or costly drugs, and distinct patient demographics across different regions can certainly affect the direct applicability of every single recommendation.
So local context matters.
It absolutely does. For instance, access to anabolic agents might be restricted in some healthcare systems, or the affordability of long-term denosumab therapy might be a major barrier for some patients. However, it's vital to recognize that the core principles and the underlying pathophysiological understanding presented in this consensus align remarkably well with broader international guidelines, such as the widely recognized KDIGO 2017 CKD-MBD guideline updates. So while direct verbatim implementation of every single detail might require some adaptation based on local realities, the fundamental strategies remain globally relevant. Things like the absolute imperative for early screening, the critical role of assessing bone turnover status, the concept of tailoring treatment based on both bone turnover and EGFR, and the non-negotiable importance of managing ROD first. These are universally applicable concepts.
So adapt the specifics, but keep the core principles.
Precisely. You might need to adapt specific drug choices based on local availability or cost-effectiveness analyses. You might need to modify screening frequencies based on local resource limitations or access issues. But the underlying philosophy of care outlined in the consensus remains sound and valuable. This consensus truly highlights the ongoing need for region-specific adaptations of global guidelines, acknowledging local realities. And it also underscores the value of continued localized research to further refine and validate these approaches in diverse populations worldwide.
Okay, that's a balanced perspective. So after this comprehensive deep dive, pulling it all together, what does this mean for you, the clinician listening today, and maybe for the broader future of managing osteoporosis and CKD? How does this consensus really move the needle for our patients?
Well, ultimately, this consensus provides meticulously crafted, highly practical framework that is explicitly aimed at improving patient outcomes and effectively addressing the inherent complexities of osteoporosis when it occurs in the CKD population. It clearly underscores that while further large-scale randomized controlled studies are definitely still needed, for example, we need more head-to-head comparisons of long-term outcomes of different agents in specific CKD stages, perhaps exploring newer therapeutic targets. The evidence we have now strongly supports the key recommendations. These are embracing a multidisciplinary approach, recognizing the imperative for early and proactive screening, and implementing those tailored treatment strategies that are precisely guided by both bone health parameters like turnover markers and BMD, and the underlying CKD status, particularly EGFR. These are paramount actions clinicians can take right now.
So it provides actionable guidance for today.
Exactly. It moves the needle by providing a clearer, more unified expert voice on how to approach these complex patients systematically. The journey towards achieving optimal bone health and preventing fractures for these vulnerable patients is undoubtedly ongoing, but this specific Indian consensus represents a significant and valuable step forward. It provides clearer, evidence-backed guidance for clinical practice, helping you navigate these complex waters with greater confidence and ultimately deliver better patient care.
That's a great summary. And maybe a final thought to leave our listeners with. In a world where the prevalence of chronic kidney disease is unfortunately increasing, truly understanding these unique bone health challenges and embracing these tailored, evidence-backed approaches isn't just about treating a specific disease, is it? It feels like it's about fundamentally improving the quality of life, preserving mobility, preventing those devastating outcomes for truly vulnerable patient population. So perhaps the question for all of us is, what more can we as clinicians do to not only rigorously apply these guidelines in our daily practice, but also perhaps contribute to the ongoing research that will inevitably refine and expand them, hopefully for an even broader, more global impact in the future?